Welcome to the fifth annual Technical Aspects of Lead Extraction Symposium, or better known as TAILS. I'm Dr. Robert Schaller from the Hospital of the University of Pennsylvania, and I'm thrilled to have you join us. At TAILS, we bring together a diverse group of experts from around the world to share insights and strategies on lead management and extraction tailored for learners of all levels. Each year, we're proud to welcome an audience of over 1,000 participants and we make all of our talks immediately available at tailssymposium.com. And most importantly, Tails remains committed to be completely virtual and free, ensuring open access to education for all. In order to accomplish this, we are dependent on our industry partners who have supported Tails throughout the years. And this year, we'd like to thank our global sponsors, Medtronic and Philips, our partners, Abbott and Boston Scientific, our contributors, Biotronic, Inari Medical, Kestra Medical Technologies, Merit Medical, and Zoll. And we'd like to thank our industry partners for providing educational grant support as well, including Abbott, Boston Scientific, Merit Medical, and Philips. TAILS is supported by a grant from the Penn EP Educational Fund and is hosted by the University of Pennsylvania EP program, and our organizer today is Mediasphere. Today, I'm joined once again by our Associate Program Directors, Joshua Cooper from Temple University and Mohammed Sadiq from Toronto. Here's a list of our esteemed faculty who you'll get to know in a few minutes. Our schedule at a glance is similar to previous years, where we will have sessions titled Tools and Techniques, Emerging Concepts, Special Scenarios, and then we'll have a lunch break. But this year, we'll be adding a very special case presentation during the break, which will be presented live, and you're not going to want to miss that. And then we'll conclude with case presentations, which will be presented live, as well as practical aspects. If you'd like to claim CME, they will be available at the immediate conclusion of TAILS on the CME accreditation page. This year, we're joined by a very special guest, Dr. Jay Schloss, the Medical Director for Cardiac Rhythm Devices at Christ Hospital, who will be providing his expert perspectives in real time throughout TAILS 2025 on the Twitter or X platform. Please follow him at EJSMD, hashtag TAILS 2025. He'll also be joining us at the end of the program to provide some of the highlights from social media today. So without further ado, we will start with our first session entitled Tools and Techniques. I'll be moderating this session, and we'll have talks from Drs. Charles Love, Rob Lewis, and Gareth Witt.
Hi, this is Charles Love. I'm very delighted to be here as part of this annual excellent conference. I've been asked to speak on new extraction tools, present and future, and I'm going to give you my disclosures here. And I think that one of the things that is very helpful is to kind of put into perspective how we got to where we are first. Early method and techniques involved open surgical extraction, direct and mechanical traction methods, but these had high complication rates, were very inconsistent, and involved significant morbidity and even mortality for the patients. Pre-1985, this was an open surgical procedure, even used weights and pulleys to slowly put more and more traction on the leads, and eventually, hopefully, the lead would come out, the heart would stay inside the patient, and things would work out okay. But again, very inconsistent and simply not a reliable way of managing lead complications. Around 1985, Dr. Bird began to remove leads by simple traction, and leads would still break during the process due to the lack of tensile strength. So you'd end up with a kind of a big chunk of meat at the end of the lead, not a really great thing to do. Around that same time, there was some work by Dr. Jorge Maibaum, along with a guy named Louis Good, who was an engineer working for a pacemaker company at Cook Medical, selling temperature-based pacemakers. But in any case, they became interested in using a locking stylet to add beef, add some stiffness to the lead. And this was all done separately from the work by Dr. Bird, who then began using some dilator sheaths that he had custom made. And these are generally utilized for what we still do today, which is applying traction to the lead and using the sheath for counter traction to maintain or to limit the stress around the tip of the lead where it meets the myocardium, pulling the lead out, embracing the myocardium as you do that. That's still the same principle we use for virtually every lead extraction technique today, except for a new one that we're going to talk about a little bit later. And this is an example of the early sheaths. They were Teflon, they were plastic, again, very simple in their design. This is the actual diagram that Louis Good came up with, looking at both a sheath system as well as this very simple stylet with a little piece of wire wound around the end that you could twirl the stylet and it would lock into the tip. We had to have like 25 different size stylets, one for virtually every 1/100th of an internal diameter of a lead. So we've got new stuff now that we'll talk about. And this was a great combination. So Charlie was using the sheaths alone at the time, but the leads were breaking in the process. And Louis Good brought this locking stylet down to work with Charlie. And Charlie used the locking stylet and the sheaths, and voila, it was like peanut butter and chocolate. We had a great combination, something that really worked well. The next iteration was something to kind of bore through this very dense tissue and calcification that's sometimes underneath the clavicle and between the first rib and the clavicle. And we came up with these stainless steel sheaths, but these are very inflexible. They would cut the leads, but they were effective if you had to use them. Subsequently, around 1994, we came up with the laser. This was the first iteration of the laser, and the first use was by Dr. Bird. I was the first cardiologist to utilize it. I did a second case. This is actually inside a reanimated dog heart called the Visible Heart that I did at the University of Minnesota, courtesy of U of M and Medtronic, who helped sponsor this particular work. The laser has multiple fibers around the end and is still one of the workhorse lead extraction devices that we utilize today. The main difference between the older sheaths and the newer ones is really the ability to utilize an 80 hertz repetition rate instead of a 40 hertz repetition rate. So you get through stuff a whole lot faster. But you got to have better locking stylets than we had, and that there were two different iterations that came up. One by Spectranetics that is a kind of like a Chinese finger cuff. It's a mesh of wire pulled against a stylet. And you release the mesh and it locks inside the lead and gives you traction to pull out the lead and gives you some more stiffness of the lead so you get a good rail coming down the lead. The other form was the Cook Liberator locking stylet, which has got a little spring of nitinol wire that goes through a very thin tube. This whole thing's like about 0.12 of an inch. It's very, very small. And you push this tube forward, it compresses the spring and causes it to lock inside the lead. And this is a one size fits all, and you don't have to use these gauge pins and all sorts of stuff anymore. Still something that's very, very useful. We use it all the time. There was a brief utilization of electrosurgical energy. This is a standard Valley Lab force for the electrosurgical instrument, and it was paired with a specially made Teflon sheath with a bipolar tungsten electrode at the very end of it. And this was utilized to electrosurgically dissect through binding sites, but it was not super effective, and there were some complications associated with it, so it's really become obsolete. One of the best tools that we have right now is the Cook Evolution rotating mechanical sheath. This is the first iteration. It had this spiral at the end of it, and you would pull the handle, and that spiral would go around in a kind of a counterclockwise fashion here, and this would bore through things. But unfortunately, this would also cause kind of lead wrap. It would only go in one direction, and it would cause wrapping around other leads, other structures, wrap up the vein, wrap up the other leads, and it wasn't the greatest tool, but it did allow you to kind of really get through things like calcified tissue. Laser's not very good with calcified tissue. Mechanical is much, much better with that. After that, we got the Cook Bulldog lead extender, and this is still a great tool to utilize today. If you don't have a stylet, if you don't have a lumen in a lead, or if you've got a lead that's kind of been broken, you can't get a locking stylet into it, you can grab onto it with this Bulldog lead extender. It's basically a snare that holds on to the end of the lead. And you can also use this short and aggressive tool. This is the Shorty, which is kind of like an evolution. It's basically an iteration of evolution. It's shorter and has a much more aggressive cutting tip on it. So if you're trying to get under that clavicle, you're trying to get through the calcified tissues, you're trying to get through dense stuff, this will get you in, but it won't get you very far. At the same time, they came up with the Evolution RL. This is a great tool, again, to get through calcified tissues and very dense tissues. It goes right, it goes left, clockwise, counterclockwise each time you pull the handle. And you can actually pull the handle just part way, you can release the handle just part way. And if you only release it part way, it'll keep going in the same direction. I find this very, very useful in order to get through calcified areas and very dense adhesions. It is not very flexible. If you need flexibility, the Tight Rail by Philips Spectranetics, it's nice and smooth on the outside. It's got this little dilator in here. It only comes out 2/100ths of an inch, rotates 540 degrees. You bring it along till you get into binding sites and you kind of chomp through the binding sites. I like this because it's nice and flexible and the tip is very smooth. So you tend not to cause too much damage to the vena cava as you might with some other types of techniques. Another iteration of the Spectranetics tight rail, this is the tight rail, is the sub C. It's kind of like the shorty. It's shorter. It's got a more tapered end here and a more aggressive cutting blade. So again, it helps you get underneath that clavicle and get through those binding sites very nicely. A tool you really don't want to be without right now is the Spectranetics Bridge Balloon. This was developed by Dr. Roger Carrillo, and I think my face is right over his, and Jude Clancy. This has become a great rescue technique. It has improved our mortality statistics from a 50% mortality to a 10% mortality for SVC tears. This balloon is blown up inside a porcine model. It's a live pig. We lacerated the superior vena cava. You can see it's essentially a bloodless field over here, and you can do a primary closure on that SVC. You can bridge them until they get to surgery with much, much lower blood loss. Terrific tool. Don't want to be without it. One of the newest tools, which many of you may not be aware of, is the XCardia extractor device. So the XCardia device is unique in that it is a mechanical, electrically powered tool, uses a foot pedal to power it. It's got a switch on the side too, but I like the foot pedal. And it has a deflectable tip at the end. So you can steer this, you can actually deflect this to make it around the bend from the right side into the superior vena cava or coming across the innominate vein from the left side and make that bend into the SVC to maintain a good coaxial alignment. Very, very useful to get through these tight bends. And it also, your hand doesn't get tired because it's electrically powered. And I like it because it's mechanical and it'll bore through those tough kinds of things for you. It's got limited clinical release right now. The company is kind of circling their wagons and getting a new vendor for production. So you should be seeing this out in wider use towards the end of this year, I would hope. This is what it looks like inside the vasculature. You can see just how flexible it is. We steered around and you can just see it kind of chomping right along here. It does a really, really good job of getting through those tough binding sites. A very recent technique is that of utilizing the shockwave lithotripsy balloon to try to break up calcifications inside the vasculature. There's some case reports on this. We don't have any kind of randomized data. There's a lot of anecdotes about it. I've used it a couple of times. And the idea is you take this relatively small unit and you use this balloon that's on a catheter and you place the balloon inside the blood vessel over a wire. You blow the balloon up and you deliver high frequency, very powerful shock waves, the same kind of shock waves that are utilized to break up renal nephrolithiasis and that kind of thing. And the idea is you can break up the calcium and be able to get your sheath over it a little bit easier. This is a fluoro of a patient that I extracted utilizing this technique. You can look at these leads. They're very heavily bound in here. You don't see any movement along the innominate vein. They're really kind of bound down here, and they're kind of stuck up against the vena cava over here. It's actually a fracture on this distal fragment over here. So what we ended up doing with this is because the vein was occluded, I came up from below and we loosened up the atrial lead, which broke free, and we grabbed a hold of the atrial lead with a snare here. And once we got a hold of it with a snare, we were able to pull the lead out. And here, this is the lead and the snare are pulled into the sheath. We pull everything out, and then we use the snare, actually the sheath that the snare was within, to place a new guide wire. And once we were able to do that, we went ahead and did a pre-treatment with the lithotripsy balloon here. And down here, we actually did this a number of times. I'm not going to show them all to you. And then we went ahead and were able to get all of these leads out. And I'll just give you the money shot here. This is a snare coming up and grabbing hold of this last piece. This is actually a tight rail from below with an Agilis catheter inside so we could help steer things. And we utilized an end snare to grab a hold of the lead tip here. And you can see we were able to get this thing out in its entirety. The only wire up there right now is the stiff wire for the bridge balloon. So there's one new device that is just undergoing clinical studies. First in human was just done this last year, and it uses vibration alone, no lock, no through a locking stylet, but no sheaths are being used. So it's got this vibrating device here. There's a locking stylet. There's no sheath being used here, just this vibration machine. You can hear it. And just with vibration and mild traction, the lead will pull out. This was a 7-year-old ICD lead. I'll show you what it looks like here in just a moment. This is what it looked like on the fluoroscope. Same lead, same procedure. You can hear there's the vibration. They just put a mild traction on it, and boom, the lead just will come flying out. Very, very amazing. And this is what the lead looked like. This was actually fairly fibrosed, fairly encased in fibrosis. So interesting technique. First in human was done in Europe, and we should have it undergoing clinical studies in this country later on this year. So as far as future evolving technologies, we have the extract device that I just showed you, potentially new laser technologies, little different wavelength, enhanced imaging techniques. That's probably another talk here today. Smart devices with maybe improved biocompatibility. We'll see probably new materials to reduce tissue adhesion on leads, alternative energy-based devices, perhaps, maybe more use of shockwave balloons if we can prove that there's actually an advantage to using them. And again, we want to continue to minimize procedural risks even further. The challenges are the high cost of new technologies, the learning curve for operators, and potential regulatory hurdles. So that's what I've got for you today. And thanks very much for being part of the TAILS annual lead management meeting. And then thank you to the sponsors as well.
Hello, everyone. My name is Rob Lewis. I'm at Duke University. I'm going to talk to you about how lead bench testing can affect transvenous lead extraction in clinical practice. I'd like to thank Rob Schaller for the invitation to talk today. Disclosures. All right, so topics I want to cover in this talk are how we traditionally acquire lead management knowledge and how that gets disseminated to our community, the role of bench testing and what role that might play in clinical practice, examples of bench testing, a couple experiments that I had the fortune to participate in, and what the future holds for lead bench testing. So traditional accumulation of knowledge is generally a slow process. It's acquired case by case, and a lot of times the experience is pretty small. People get that experience, and then sometimes we make some pretty bold statements about how things should be done. But again, really, that's based on a pretty small patient selected group. There is no ability to control variables when you're in a clinical setting, and you can't go back and attempt different techniques to really determine what's superior to something else. You may find a technique that works, but that doesn't necessarily mean that it's optimal. I've got a interesting cartoon over here, which I think really sums up sometimes what we do in lead management. You got a group of folks here pushing a wagon with square wheels down the road, and it happens to be filled with tires, which is pretty ironic. But this, of course, works, but it's not necessarily the optimal way to do things. It's possible that the optimal technique is found quickly, but usually this is after years of experience. And again, a very slow process because of the inability to control variables, the unlimited number of variables, and the small case numbers. So where would bench testing fall into this? Well, what if we could develop a model where we could approximate extraction forces in an environment where we can, number one, control all the variables. So we can determine how much scar we're simulating, where the lead's attached, how the lead's attached. We could test multiple scenarios and techniques. We can go back and do different things with the lead and see what really works best. And we can evaluate lead performance under extreme stress, something that we can't really do in the clinical environment because we don't want to pull on a lead so hard or really stress a lead so hard that it falls apart in the clinical environment. But in bench testing, we really don't care. And this will give us an idea into the mechanisms of lead failure and how we can better address those. If it doesn't give us the exact optimal way to do things in a clinical setting, at least it lets us narrow the search. So we don't have to start with every option that's possibly available. And we can really, again, narrow that search and see what's out there that would potentially work in the clinical environment. So let's think of a question where the lead extraction community has some equipoise or at least some difference in practice. I'd say one of those areas would be how to prep a co-radial lead. And the quintessential one of those is the fine line. I don't know that anybody really loves extracting fine line leads, but there's at least some, if not equipoise, some a little bit of disagreement on how to prep these leads. Some people will cut the terminal pin, shown here in this picture. And in doing so, that tends to be a quick way to prep the lead. It also keeps the diameter of the lead pretty small, so you don't have to worry about upsizing your tools. But unfortunately, one of the cons to cutting the terminal pin is that you expose the co-radial lead design and potentially make the lead weaker. If you decide to keep the terminal pin intact, you usually shave off the sealing rings shown here to help make it a little bit smaller in diameter. But if that's not difficult to do, it's at least timely and takes a little bit of effort to get done correctly. And then you're still dealing with something that's a little bit larger and difficult to fit into some of our lead extraction tools. So like I mentioned, I had the pleasure of working on some benchtop lead experiments with Pierce Vatterott in Minnesota and some really brilliant engineers from Boston Scientific. We looked at a couple different things. One thing we looked at is with all their Brady lead families, the fine line and the Ingevity. In the Ingevity family, you have the original Ingevity and the Ingevity Plus as well. And we looked at what mechanisms there are of lead failure, how the leads fail, and then some things that we could change, whether it's with lead prep or the way we extract the leads, to make failure less likely in the clinical environment. So before we get into that, I want to talk a little bit about the basics of these leads. So if you look at the Ingevity family, there's a lot of talk about trifilar and single filar design, but really, if you just try to put them into a broad category, they're just coaxial leads. So they're a cathode wrapped internally inside the anode, which is again wrapped around the cathode, and there's usually an area of insulation between the two. The fine line, as I said before and alluded to, is a co-radial lead. So you have the cathode and anode wrapped together. You can see that here, and then insulation on the outside of that. One area that becomes very important when we start talking about lead failure, we're going to address this in just a second with these particular leads, is this area that's highlighted here that's labeled as the flexible neck. This is the area between the anode and the cathode. And we're going to talk about the mechanisms of lead failure that occur at this flexible neck, or in the fine line, it's referred to as the outer tubing. But either way, this becomes a very important area of lead failure. So here's the leads we looked at in this experiment. Again, as mentioned, we looked at the Ingevity leads. Again, just to keep in mind, the overall 10,000 foot view design of these leads, they're just co-radial leads. There are some leads that are the Ingevity Plus or trifilar, and the Ingevity leads have a single filar design. They come with outer insulation that is polyurethane, and then that insulation that's between the anode and cathode is a silicone. When you look at the fine line, again, co-radial lead, and the outer insulation comes in a combination of polyurethane or silicone. So here's our model. Our model was made to mimic a right atrial lead placement. So in this model, in this area here, this kind of little clamp, we have what we call a simulated atrial myocardial wall, or as abbreviated in our study, SAMW, sorry about that, simulated atrial myocardial wall. And this is the attachment of the tip of the lead to the right atrium. We then have a series of pulleys that work to give us different, sorry about that, give us different levels of scar within the vasculature, and also in the right atrium. Variables that we looked at, as mentioned before, one of the variables that I think is a question amongst the community is whether or not to leave the terminal pin intact. So we looked at both cutting the terminal pin off and leaving the terminal pin intact and how that affects lead failure. We also looked at various locking stylettes used, the LLD systems from Philips and the Liberator system from Cook. And then lead binding mechanisms, we looked at just Plano suture. In this case, we used fiber wire, and the one-tie compression system from Cook Medical. So here you can see an example of this experiment going in real life, broken down into panels A, B, and C. So here we're just starting, and you can see the simulated atrial myocardial wall. That leads attached, the locking stylettes all the way at the tip, and everything seems to be pretty much in line. In panel B, you can see that that flexible neck is starting to stretch. And as that flexible neck is stretched, the inner coil of these leads is starting to stretch as well. You can see that under fluoroscopy demonstrated here. A lot of people refer to this as locking stylet slippage, when really what that is the inner coil of the lead starting to expand and decrease in diameter. So this lead is under a significant amount of stretch. So we're already stretching the tip, and we're starting to stretch the inner coil as well. So we're really yanking on these leads. Again, we can do this in a benchtop setting where we don't care about lead failure. What we found is there's this common mechanism of failure amongst all these leads. So I mentioned the flexible neck or the outer tubing before. So the first thing to fail is the flexible neck starts to stretch, and then you have a tear in the flexible neck. After that happens, all the load is then forced onto the inner conductor. That starts to expand and decrease in diameter until it gets to a point where it breaks, and then you have total lead failure, and the lead comes apart completely, and it won't allow any more load sharing. So here you can see this graphically. Load is on the y-axis, and extension or stretch is on the x-axis. And as the load increases, initially there's no stretch at all, but then the flexible neck starts to stretch, then it breaks, and then all the load is then put on the inner coil. You can see that inner coil continues to expand until it gets to a certain stretch or expansion, and then a certain load, and it breaks as well. And then you have total lead failure. When we looked at the Ingevity Plus in the fine line, we saw a little bit of a difference. I think the difference is mainly within the coaxial versus co-radial design. So when we look at the coaxial design of the Ingevity Plus, you see that similar mechanism of failure where the flexible neck or the tubing, the outer tubing, stretches as the load increases and then breaks. And all the load at that point then goes to the inner coil. It does that with both lead systems. When it goes to the inner coil of the Ingevity Plus, which is again coaxial design, it allows for a little more load sharing as it expands until it breaks, and then you have complete lead failure. With the fine line, again, co-radial design, you don't have as much ability to support further load. You have a lot of extension or stretch on the x-axis, and then ultimately the load reaches a point as well as the extension where you have the coil break, and then you go to total lead failure. So now that we've discovered how the lead breaks, again, we wanted to look at some things that we could do, some variables that we could change to see if we could alter, at least make it less likely for this lead to fail in clinical practice in an actual lead extraction procedure. So one of the first things we looked at was whether or not to keep the terminal pin in place. So in this experiment, we looked at all the lead families, and in some of them we cut the terminal pin off, and others we left the terminal pin in place. We prepped the leads with our locking stylets as mentioned and suture, and we started pulling to see what would happen. And almost universally, either clinically significantly or statistically significantly, leaving the terminal pin in place allowed the lead to tolerate a higher load than cutting the terminal pin off. There were a few outliers in the fine line silicone leads and the Ingevity passive fix leads. There wasn't in the fine lines, there wasn't a change between the two, and in the Ingevity passive fix, it actually went down a little bit in the amount of load that it would tolerate, although not statistically significant. So in summary, it kind of leaving the terminal pin in place either helps you, sometimes significantly helps you, or at least doesn't hurt you. So it tends to give the lead a little more load tolerance. One of the downsides to leaving the terminal pin in place is you do really have to upsize your tools. So you're now looking at a 9.6 French IS-1 terminal pin being in place. So now you're up to at least a 14 French laser. It's a 10.2 French inner diameter on a 14 French laser, or an 11 French tight rail to take these leads out. One of the other techniques we looked at is exploring both a superior and an inferior approach with a needle's eye snare. And you can see here that when we snare this lead, this isn't a typical bailout strategy type snare. This is something where we snare prophylactically at the beginning of the case. So you can see that the locking stylet is all the way at the tip still. And what we've done is really snare the locking stylet. So now we've shifted that load to the locking stylet, taken it away from those fragile components of that flexible neck and internal coil. And now we're extracting something that's much stronger. So you can see here, this is an example with the fine line polyurethane lead. One thing we didn't talk about is the difference between scarring and the ability of heavy scar to allow higher force tolerance. But that's really not the point of the slide. What I'm showing you is the same lead. When you snare it, can tolerate almost 3 times the amount of force, because now you're actually extracting the locking stylet instead of those fragile components of the lead. I would be remiss if I didn't mention a great paper that was also written, led by Pierce Vatterall and the late great Bruce Wilkoff, where they looked at the 3830, so lumenless lead. Due to time constraints, I really don't have time to get into it, and I wasn't on this study, so Pierce would be a much better person to talk to about this, but I did give you the reference at the bottom if you want to read it. Another well-written paper, benchtop testing, looking at what's happening with these leads and things we can do in clinical practice to improve our success. So the future of bench testing for transvenous lead extraction, I think there's been a lot of industry support, or at least interest, in how these leads perform terminally or at the end of their life when they're being taken out of the body. And I think there's more focus on that. People realize that really affects how people feel about the leads long term. It helps expedite the discovery of best practices, but it must be remembered that the benchtop does not equal the human body. So while we can start to limit some of our options, we still have to look at these in clinical practice because some things might be different. Thank you for your time.
Hello, my name's Gareth Wynne. I'm, as it has likely just been mentioned in the introduction, I'm a lead extractor electrophysiologist and cardiologist at Royal Melbourne Hospital in Australia, and I'm very pleased to be back again to Tails to be talking today on extraction or abandonment of non-infected leads. And one of the reasons that this comes up is that we know that in occasionally the diagnosis of infection is difficult to make. In reality, once a device infection has been diagnosed, there's rarely significant debate about the central role of lead extraction in managing confirmed pacemaker or defibrillator infection, such as this case we had about 6 months ago. However, the question of how to best manage superfluous non-infected leads remains contentious. From well before these contrasting opinion pieces were simultaneously published in 2010, through to this contemporary review published only a few months ago, the debate continues to rage, hampered in its ability to reach a definitive conclusion by an almost complete lack of randomized controlled trials in the area. I mean, you'll see later on when we go through some of the guidelines that there really are no high level of evidence statements supporting any of the information we have. We'll try to add to a little bit to it today. Clearly, this decision regarding lead extraction or abandonment requires comparison of the current risks of lead extraction with the future risks of both lead abandonment and potential lead extraction of those abandoned leads. There's never a zero risk option. And here you can see that from one of these papers I mentioned earlier, a balance of risk versus risk. And I think this is an important thing to think about when you are both considering lead extraction in these scenarios and also, of course, talking to patients, because it can be very easy to give an impression that there's a zero risk game in one side and the other is all risk. But really, we're talking about balancing the long and short-term risks, some of which are relatively well known and some of which are uncertain. Patients, their carers and physicians have to weigh up numerous factors, many of which, as I mentioned, are partially unknown, in deciding the correct strategy for each patient. And very often, the scenario that we're facing may be unique, or at least near unique, based on a number of factors relating to that patient and their device. When we look at the consensus statement that was published a few years ago by the HRS and many other societies, they look at giving guidelines. And as I mentioned, you can see here the level of evidence through here are all relatively low, reasons why we should or shouldn't remove leads that are not infected. Some of these are relatively uncontroversial. This, for example, extraction for chronic pain, is not really an extraction versus abandonment issue. It's really more whether we think this is something we should intervene over or refuse intervention based on prohibitive perceived risk. But if we think the risk is acceptable, and we'll talk a little bit more about that in a moment, then clearly this patient is somebody who needs something done to improve their quality of life. Equally, it's not particularly controversial to think that in life-threatening scenarios or potentially life-threatening scenarios, where lead extraction is thought to offer the best reduction in that risk, then we have little controversy over what we should do. And there are a number of situations where this can occur, either with life-threatening arrhythmia secondary to retained lead, which is, I think, is a relatively rare scenario in the way that it's described here. I think I've only dealt with one case of this over the years. And also more commonly is for patients who have devices, particularly generators, which may interfere with their treatment for malignancy, particularly radiotherapy. And here again, we're not really deciding whether we treat the patient in jet or we're doing lead extraction. The first question is, are we treating the patient? And then the question is, how can we manage this in the way that's easiest? And that may be lead extraction. It may be removal of the device. It may be short-term temporary scenarios. But again, not particularly controversial. As you can see here, again, some scenarios where we clearly need to do something about this list. And I don't think when we're talking about extraction versus abandonment, we're not really looking at these sort of scenarios where the situation is urgent and relatively uncontroversial. Another issue that can be something we need to deal with is vascular issues. And again, these can come in different shades. And you can see here from the guidelines that there are certain scenarios where this is very strongly recommended. And mainly these are situations where there's thrombosis, which hasn't been managed in another way due to a retained lead or retained lead fragment. Usually anticoagulation is going to be tried in those scenarios first. And I don't think many people would argue against that because you're unlikely to completely reduce the thromboembolic risk with lead extraction. There are other scenarios such as symptomatic stenosis. We all know that asymptomatic stenosis occurs quite frequently, but symptomatic stenosis or occlusion is much less common, but can be very debilitating for the patient. And in those scenarios, again, either as a treatment which is freestanding or a treatment that is combined with stenting of the affected vessels, there's little controversy that we need to take the leads out in those scenarios, particularly looking at particularly as if it may be sufficient treatment on its own, or to avoid entrapment of the lead at a later date. By the stenting. Another scenario that comes up more commonly is when the vascular occlusion is relatively asymptomatic, but the lead has created this sort of scenario where implantation of a new lead is extremely difficult. And in those scenarios, lead extraction may be the only real option in order to maintain pacing or defibrillator therapy for the patient. What we're really talking about here is when there's controversy as to whether the lead should come out or not. The genuine choice is there's no immediate risk to the patient, and potential future threat is really is what we're looking at. There's a particular item on this which talks about threat due to the lead, which really dates back to the Acufix lead and the concerns about extrusion of an active J wire. That hasn't been an issue we've seen for a long time. And so we're talking about what are the future risks of the patients and the current risks of lead extraction. And you can see the levels of evidence drop, the recommendations now drop down to 2A and 2B, with the level of evidence remaining poor. A distinction made in some of these guidelines between non-functional leads, which apart from the fact that they can accumulate and potentially are in worse state of repair due to the fact they have some damage that's led them to be non-functional, or functional leads that may still be working, but perhaps either shouldn't be working in the place they are, or more commonly become superfluous because of a need for change of the therapy that the patient requires. One of the big issues that comes up with this is access to MRI scanning, and this is too big a topic to cover as just a slide or two in this talk. It really is a very complex issue we have with patients, and we know that there's a real disconnect between the evidence that exists and clinical practice. And certainly in many parts of the world, and very much the case in most of Australia, getting non-MRI conditional devices scanned is all but impossible. It's rarely the only reason we extract devices, but it does sometimes end up with that, and it certainly weighs into people's thinking as to extract or abandon a lead that they may need an MRI in the future. The dangers of not doing MRI scans by the teams that make these decisions are often ignored, I think, and we know this should change at some point, but it hasn't changed yet, and I'm not sure when it will. Again, just looking at these through from the we've discussed as we go through the slides earlier on, a number of reasons why leads may need to be or may be thought of as reasonable for extraction, none of which have an immediate consequence, and therefore we have a real decision to make in the patient about optimizing risk. When we look at the risk profile, and we look at papers like this one by Ritika Parakesh, published in 2012, where sprint Fidelis leads were removed, you can actually see here that the overall rates of major complications over to the left of this graph are not particularly different between the two strategies of abandonment or lead removal. But here, when they look at all complications, there's clearly a higher rate of complications in the lead extraction group, as one might expect for a more complex procedure. And the question is, how do we balance that against the potential benefits? This looks at the things from the other side, and this was a paper published relatively recently in PACE, looking at a number of patients who had gone through a decision to abandon leads, and then what happened with them. And we can see that the clinical procedural success over the right-hand side here drops down to about 60% rather than the 90+% we would usually expect, with a far higher rate of major complications you would usually expect to see from a lead extraction scenario. And one of the really useful things from this study was looking at, in this observational group, how often did patients who underwent abandonment go on to need extraction, and here they found about 9% of those patients progressed. Of course, that underestimates the patients who maybe should have gone on to have extraction, but this didn't occur, either due to perceived high risk or other reasons why they were managed in a more conservative manner. The Electra study from Europe still remains the largest registry we have, and they looked here in a sub-analysis about outcomes for patients with abandoned leads. And this ties into what we saw in the last couple of slides, that a greater lead burden and greater dwell time obviously occurs when leads are abandoned. When leads have been abandoned, there seems to be a higher rate of infection, and having previously abandoned leads can increase the procedural complexity and alter the rates of clinical failure and complications. Again, just mirroring what I showed on the study just a few slides beforehand. So this comes from the 2018 ERA guidelines, as shown here as a gap in evidence, and this is what we're talking about here, that the management of abandoned or recalled leads is a challenging process. And we haven't really potentially or clearly defined the risks associated with lead abandonment and whether the potential benefit justifies the risk of the procedure. In terms of potential benefits, we've talked about these over the last few slides. One that I think is coming into much more prominence is the concerns about leads going across the tricuspid valve. And I think we have for many years as a cardiology community, as a pacing community rather, underplayed this risk for patients for right heart failure and symptomatic deterioration that now perhaps we're all becoming a bit more aware of, and certainly weighs into my thinking of making an extraction versus abandonment decision, in that I'm more likely to take a ventricular lead out than an atrial lead because of that as an additional issue. Of course, as a lead extraction group, we know that lead extraction has some risks, and we're talking about a defined current risk against an uncertain future risk. Tricuspid valve function, as I said, is an important issue, but of course, anyone who does lead extraction knows that damage to the tricuspid valve is also a serious concern for us and does occur in around 1% of cases. If we're extracting for MRI, we don't always manage to get all the leads out. And if you break a small part off that can't be removed, that certainly precludes the patient from MRI in the foreseeable future. And lead extraction is not a cheap or logistically easy process to do, which is why one of the reasons why trials of this are difficult is a lot of these decision-making processes occur outside major lead extraction centers. In terms of predictors for risk, I'll skip through these a little, but we need to look at both the patient factors of general health, such as age, low BMI, other comorbid conditions, venous occlusion, prior stenotomy, which may or may not be protective against major complications, and also device factors, which talk about the number of leads, how long they've been there, the type of leads that are there, the fixation mechanisms, and where those leads are. Device factors really decide whether or not we're likely to have a major complication, and the patient factors then go on a little more into whether, if we do have a major complication, and we really talk about needing stenotomy here, as to whether the patient is likely to survive that. And I think that's a useful way of looking at these scenarios. In terms of trying to answer this question, my group has looked at this, and we've gone through and are in the process of preparing a manuscript, having analysed the data that exists, all of which is observational. And we try to do this as definitively as possible by conducting this systematic review and meta-analysis. And we found 23 eligible studies reporting over 65,000 patients to look at two fundamental questions. We looked at whether, when we were considering the procedure of lead extraction and abandonment, which procedure was associated with a better risk profile, and we could see that short-term data favours abandonment with lower rates of mortality and major complications. When you look at all complications, as it gets a bit more nuanced, and we suddenly cross the line of no difference here. And when you look longer term, actually, there does seem to be no particular benefit from lead abandonment in terms of effect on long-term major complications of mortality. We then went on to look at patients who had abandoned leads and compare all those studies looking at that. And we can see here the left-hand slide, panel A, is the data I showed beforehand. When we look at panel B, we can see that the rates of in-hospital mortality for patients with abandoned leads are higher than those for patients that only have functional leads. These forest plots also show us the same picture when we're looking at major complications, in that they are much higher in patients who have abandoned leads. And I said, this looks at all the published data that exists. In conclusion, we know that lead abandonment has fewer intermediate or immediate procedural risks, as you'd expect for a less complex procedure. But as we've seen from the data that exists, there's no long-term survival advantage. And if you do need to go on to have an extraction in the future, you certainly have a higher risk of complications at that point. From our data, we would have thought that extraction should be at least comparable, if not potentially a superior long-term strategy to manage non-functional superfluous leads. And advancements in techniques and long-term considerations may justify early extraction in certain cases. The old mantra that a lead will never be as easy to extract than it is today does that potentially therefore apply, but of course the easiest extraction is the one that never happens, and we still don't know exactly how to predict which ones they might be. Thank you.
All right, thank you so much for three wonderful talks. We're joined by Doctors Love, Lewis, and Wynn, and we have a bunch of questions. We have 20 minutes to discuss. If you have any questions amongst each other, please let me know as well. But I think one thing that piqued the interest of the audience from Dr. Love's talk was the new vibratory tool, or potentially new tool, in terms of what the mechanism is there. That's essentially just a accentuated traction tool, right, that disrupts things locally, Dr. Love?
Yeah, pretty much, Rob. It's if you can just think of maybe like a wheel with a pin on it that goes around and around and just kind of moves back and forth. So it still uses a locking stylet to beef up and hang on to the lead. And I was very skeptical when I first heard it. I did some animal work with it, but the leads were not very old in the animal, so I wasn't overly impressed. But as they have taken on more and more long duration implant leads out to about 7 years now with these ICD leads. It's an interesting concept. Obviously, it doesn't work if you have a broken lead or something like that. But I don't know what the exact mechanism is. It seems to just kind of work like a paint shaker. It just kind of vibrates it until it finally releases.
And the thought process here is potentially with leads that aren't very old, perhaps we don't need to set up like a lead extraction anymore. Do we not need CT surgery anymore? Is this too distant to even consider at this point?
Yeah, I think it's still a very nascent technology. I
Yeah.
don't know what we don't know what the potential risks are of this. Obviously, the one of the other major issues with this is not being able to maintain access to the venous system. So if this thing just comes flying out and you've got an occluded vessel, you're going to lose your access. Maybe you could snare around it, as was just described for the fine line and leads, that kind of thing, which I think is a great technique, by the way. But there may be some ways to do that. But I think the intent of this technology is exactly as you're implying, is that if we can have a quote unquote safer methodology to remove leads and not need to have all of this backup surgery and all the other things that we end up doing, that would be terrific. But again, very new technology. Stay tuned. Maybe next year we'll have some more data. We'll certainly have more data from the United States, which we're hoping that should start clinical trials later this year in the US.
Well, I'm impressed with the new technology that is emerging because it's been a long time since there's been a new tool. And there's this saying in lead extraction that a lead is never easier to remove than it is today, owing to the fact that they get harder with age. So is the engineering progress now outpacing lead dwell time, and we can no longer use that excuse to remove a lead early, or not yet clear?
Oh, I think that's certainly not yet clear. I think there's still, leads we're taking out now. We remember when we started doing this stuff in the 80s and 90s. An old lead was 7 years old. They used to give us the willies. And now we're all taking out leads that are 20, 30, 35-year-old leads now that I'm taking out. And I don't know that a little vibrator tool is going to work on that when they're all calcified and bound in like that. But I think we still have plenty of room for innovation and for the development of new tools, new technologies to make this more effective and to make it safer.
Yeah, I think it's very exciting, but until then, yeah, we do things the same way. A question for Dr. Lewis. What do you do when you can't get a locking stylet in a lead? Maybe it's fractured and there's no lumen to get a locking stylet in. With a pacemaker lead or with a defibrillator lead, you might have some extra conductors to pull. Do you proceed? Does it matter? Are there other variables to consider?
Yeah, I think I think one of the things I would approach with that is it doesn't mean the lead is unextractable. You might be forced to take out other leads that are surrounding that lead, keeping in mind that a lot of the scar tissue that's holding that lead in place might be lead on lead scar tissue, right? So if you can free up other leads around that lead, I would certainly take it out last, if that was an option. Um, I think if you can't get a locking stylet down, especially with the defibrillator lead, I mean, to be honest with you, the pace sense portion of the defibrillator lead is not your strongest components. I'm sure everybody on this panel has taken out, some Riatas and some, some other complicated fractured ICD leads without locking stylets in place. I know I certainly have. I tend to, with those particular leads, I tend to switch more to some of the other mechanisms that Dr. Love was talking about with the tight rail system or which is much more flexible and easier to. I feel that I can pull less on the lead, let's say, and really maneuver that tool around. But it certainly doesn't mean the lead's unextractable. You have to remember you have all those components. Even if all you have is insulation, you still have a mechanism with which to provide traction.
Yeah, that's always a tough situation to know what to do, especially when there's lead to lead binding. Can usually get away with it with experience, but changing your amount of pulling and pushing. One more question for you, Rob. Any advice on extraction of leads that are deep in the septum? Any change in preparation?
Yeah, we actually we just recently published our experience in extracting his bundle and left bundle area pacing leads. Now, given the age of the technology and how many leads we've put in, they weren't admittedly they weren't very old leads, but a lot of we saw no real difference in our technique. We tended to not see any conduction system injury in our particular study. I know that has been reported, but we tended to extract them exactly the same. You might have to pull a little traction at the end, realizing that that lead is buried a little bit deeper in the septum than you typically want to go with your tool. We tend to use, especially in those patients, pre-procedural CT, so we can see exactly how deep it is in the septum and what the septum looks like. So we can kind of gauge exactly how far we want to take our laser and or mechanical tool when we're doing that.
Yeah, this will evolve. People have their own way of approaching these leads in the septum. CT is controversial in itself for lead extraction in general, but we'll have to see how that pans out. So I want to leave ample time for Gareth because we gave him the most controversial topic. I'm not so sure that in 20 years we're going to be any further along than we are today in terms of knowing whether or not we should remove redundant leads. So I have a couple questions for you. First, Dr. Cooper asked a great question. Very frequently, you have a conversation with a patient and you present all options, and they say, "What do you recommend?" What do you do in that situation? Do you tend to be more conservative because they're not giving you a firm answer, or do you just do what you think is best?
Yeah, I think that's a hard question that we get, and you get what if I was your mum or dad or something like that? And often I'll go back and say, look, I can't give you that answer because we all have our different takes on risk. I think if the patient is really uncertain, then we should be less aggressive and more conservative. I think there is some evidence, but as shown, there's no randomized evidence, and in reality, the randomized evidence is probably going to be very difficult or impossible to achieve. Most of the extraction abandonment decisions are made at small centres on the day, and not necessarily at at sort of big extraction centres who maybe are running trials on these sort of things. And one of the things we noticed when we looked at this systematically is most of the follow-up is a year or two or maybe a few years at best, and you're always going to really struggle because one would expect that in the short term the less aggressive, the more conservative approach applies. And we see similar arguments about the sort of percutaneous valve interventions and surgical valve interventions, that of course if you take a more gentle approach to begin with, you're going to have lower risk. So I think it is really hard to give patients that guidance. I think, as you said, if they're really not sure, then probably the sensible thing is to be more conservative. And the other thing is just to present them as much information as they can do about what we do know and what we don't know, and hopefully get them to come to the decision. I think tricuspid valve complications and difficulties with pacing has changed my view a little bit on this in recent years, as the interventionists have led us to look a little bit more about what's going on with the tricuspid valve. And so I think I do now have a slightly different approach for atrial leads and ventricular leads because of that issue. There's no really good data to guide patients on if they don't know.
Yeah, I think that's controversial as well, because you don't want a lot of leads across the tricuspid valve, but that's also don't want to introduce the risk of tricuspid valve injury, which doesn't exist when you're removing a right atrial lead or a CS lead. And we also have to worry now about TTVR, or percutaneous transvenous leads, valves going in, and we don't want to jail these leads. So I'm going to push you a little bit, Gareth. What are the most compelling factors that you consider when you're thinking about removing a sterile lead? Is it age? I assume no one's removing a redundant lead from a 90-year-old, but a 20-year-old, most people would. Is it the age of the leads, prior sternotomy? What are maybe the top three factors that usually helps you make a decision?
Yeah, I think there are a number of models that attempt to look at risks of lead extraction, but I don't think any of them are particularly good, because when you look at all of them, they all seem to miss out fairly big factors. I think lead age burden is important. So sort of something effectively multiplying the number of leads by the time of, or adding up the time that each particular lead has been in there, to give you a total lead age burden is quite useful to giving an idea of how complex the procedure would be. So I think that's one of the big factors in terms of deciding whether or not to extract. I agree with you that younger patients are more likely to want to extract from, because of that accumulative risk of problems, and also the longer period of time that they may run into issues. And the reverse is true for older patients. Of course, for younger patients, they have the most to gain, but also potentially the most to lose. If you do have major issues, particularly if you have a fatal complication, the quality of life years lost is greatest in the younger, healthy patients. And then I think it's, what is the reason that they want to consider extraction? And this is where MRI often comes into it, particularly in Australia, which is actually a really complex conversation to have with patients when you say, look, this shouldn't really be an issue, but it is. And I don't know when this is ever going to get better.
Yeah, the MRI issue is a problem. And we have ample evidence now that you can MRI almost any type of device with no risk. And to do a lead extraction for that purpose is a shame. I have a question about people are interested in the bridge balloon. So maybe all of our panelists can answer this question. The first is the bridge wire mandatory standard of care in every single case you do? And then I have questions about prepping it. So, Chuck, is it standard of care?
So yes and no. What I tend to do, if a lead has been in for more than a couple of years, then I strongly consider the bridge. And then let me explain my thinking here. First of all, if I'm going to utilize any kind of a sheath technology beyond the curve of the innominate down into the superior vena cava and along the superior vena cava, yes, I think it's absolutely mandatory at that point in time. I won't use a laser or a mechanical sheath in the SVC unless I've got a bridge wire up and or have pre-positioned and pulled back a bridge balloon. What I find one of the most useful imaging techniques is when I first step on the fluoropedal, if I look at the leads sitting in the vena cava and they're just up there kind of wiggling around in the vena cava, that tells me the risk of vena cava damage is close to zero in that particular individual. And sometimes that leads a year old, sometimes that leads 7-8 years old. But if it's wiggling around, I think you don't necessarily need to do it. I don't see a downside to putting a stiff wire up there. And if I have very old leads, ones that I'm very concerned about, I will do the procedure where I pre-position the balloon, mark that positioning on the shaft after I've inflated the balloon, marked on the syringe how much contrast that I would utilize, so that if an adverse event occurs in the cava, I don't have to go on fluoro at that point. I just push the balloon in up to that point on the shaft, blow up the balloon to the position in the syringe while CPR is going on or while the surgeon's opening the chest. You don't have to go looking at it again. But I find just looking at the lead under fluoroscopy is extraordinarily useful.
Rob, is the wire mandatory in every case, even if you don't use a tool? And how do you prep the balloon if you use it?
Yeah, so I think I don't know if it's mandatory in every case. We do tend to use it a lot. I have adjudicated some things from other centers where I've noted, where they try to put a wire up after laceration. And I'm sure you guys have all seen pictures of balloons in the laceration, actually making the laceration worse. So I would say if you're going to use the tool, at least a wire and get it in a good position. I do tend to, if I'm going to use it, I pre-deploy the balloon. I have seen examples as well where you think the balloon's going to go into a nice location, and then you blow it up, and it does this thing that we call watermelon seeding. It just shoots back down into the atrium, and then you're not occluding anything in the SVC. The other thing I would encourage people to do if they're going to use it is I would encourage pre-deployment, because the first thing your surgeon's going to do when you have an SVC laceration, especially if they're in the room, is they're going to grab your fluoro camera and throw it out of the way, right? Because they want to get in the chest as quickly as possible. We do things very similar to what Dr. Love does, where we pre-deploy it, mark how much contrast solution was used, and where the balloon was positioned with a piece of tape on the shaft of the balloon, and we can deploy it if needed without fluoroscopy, which then, like Dr. Love mentioned, allows other people to do other things, including a sternotomy.
Gareth, when do you open a bridge balloon and when do you not?
So yeah, so I think I probably have a slightly different situation to both of the other members of the panel, or three members of the panel, in that I work in a different healthcare system where we don't. If we use a balloon, that just cuts the cost of or the profit or of our extraction quite considerably and makes it much more difficult. So I do limit how often I use or pre-deploy a balloon, but in cases where I think a bit as Dr. Love mentions, where you think this lead is clearly caught up in the SVC and you're likely to want to use power tools then when leads are older, when patients are frailer. Almost always, I'm much more concerned if they've had a previous sternotomy. I think that protects generally against the risk of serious venous injury, but if it does occur, you're in a really serious situation and death is more likely, and it's going to take a long time for the surgeon to get in there. And so that's the most common time I use it. But the other thing I have differently, I think, to others is that I've trained a cardiac surgeon who does most cases with me and therefore is ready to go, and we often have the saw right next to us. And then I don't know what the role of the wire is if I haven't deployed a balloon, and I don't think my center can afford deploying a balloon every scenario. Just having a wire without having pre-deployed when the surgeon is there ready to open the chest, as was mentioned, and they want to get in there as quickly as possible, I don't know quite what the role is then.
That's interesting. You're spoiled in some ways having a surgeon right there. The one thing I would add, we're about to run out of time, is that you have to make sure that wire goes very high up the IJ or far out the subclavian, or at least buckles over itself, because if you don't have enough support, then like Rob said, you will get a lot of watermelon seeding. So I'd like to thank Dr. Love, Dr. Wynn, and Dr. Lewis for three incredible talks and a wonderful discussion.